Everybody, welcome to Alabama EMS Challenge. We've got Dr. Shea Duerring with us today and Taylor Payne. Dr. Duerring is going to be lecturing on pediatric trauma. Dr. Payne is going to be exploring the subject of infectious disease. We've got a little bit of change in process today. When you fill out your attendance form, you won't get a certificate immediately. It'll be a couple of days this time. Just had a little bit of a glitch in our system, so please be patient with us on that. And I'll be posting the link to the attendance form in the chat box if you're online. If you can't get it that way, then you can send an email to alabamaemschallenge@gmail.com to get an automated return with a link to the attendance form. And with that, Dr. Duerring, take it away.
All right, can you hear me, Wes?
Wes, is the mic picking up? Okay, cool. All right, guys. So we're going to talk about ped trauma and then a little bit about burn at the end if we have some time. So we'll start off with a case. 2-year-old female, improperly restrained in a car seat. Vehicle rolls into a ditch in the interstate at a high rate of speed. She's thrown out of the car seat in the vehicle and is entrapped. You can't really fully assess her because of the way she's trapped in the vehicle, but she's alert and fussy. She has a prolonged 45-minute extrication. After extrication, when she's taken out of the car, she's noted to be minimally responsive. There's her vital signs. There's her exam findings. She has a big boggy hematoma over her left parietal scalp, some facial swelling and injuries, bruising over the left chest, deformity over the left thigh, and some scattered abrasions. So anybody get real excited about this? No? All right. So what injuries are we concerned about? What are our first priorities? How are we going to manage this kid? And then what's our transport decision of where this kid goes and how are we getting them there? So we're going to talk a little bit more about all of that. So these are the top things that kill kids, both in Alabama and in this country. You'll notice one thing they pretty much all have in common, and that's really they're all trauma, right? So trauma is the #1 thing that kills kids in this country. It's also the #1 call for EMS for pediatrics, followed by respiratory emergencies. It is the leading cause of death in children over 1 year of age, just period. Unintentional injury accounts for 15 to 20,000 deaths, which is 30 to 50 children per day in the United States, and accounts for 9.2 million medical visits each year, with 15% of hospitalizations for unintentional injuries. So trauma is a big deal for kids because it is really in many ways what kills kids. So, and it's what leads to a lot of healthcare dollars in the pediatric world. So when we talk about pediatric trauma, we talk about what we call a trimodal distribution. So there's kind of 3 peaks of when kids die. So the first peak is the kids who die almost basically immediately, like almost at impact or at the time of injury. These are the kids who die from like massive head injuries, spinal cord injuries, damage to great vessels. These are the kids that are pretty much dead by the time we get there, okay? There's the second peak that occurs within minutes to several hours. And these are the kids who die from exsanguination, lack of an airway, things that we can fix. And then there's the third peak that occurs in several days to weeks after the injury. And these are people who die from sepsis, multi-organ failure, stuff like that. And this is what we're talking about when we see that graph. So there's the kids who die immediately, that first big peak, the early deaths right here, and the late deaths, the kids who die kind of in the ICU a week or so later, okay? So these are the ones we really care about because these are the ones that if we do our job and we do it well and we take care of the priorities that we need to take care of, those are the kids that we can save. That's the peak that we can change and have a direct effect on. And so that's what we want to focus on. Our kids to small adults, we hate to say that because they're really not, but there are some things about trauma that they can be sort of like small adults. We're going to talk about kids today, the unique problems that face the pediatric population, because they really aren't just small adults. They have different patterns of injury. They have different physiologic presentations. Their management is a little different. And they have difference in size, which changes the way they cope with trauma, right? So they have large forces that are spread out over smaller surface areas, so they get more focused blunt injury. They have less fat and soft tissue to absorb that energy, and so they translates to more solid organ and multiple organ injury underlying that. Their skeleton is different. It's less calcified and more flexible. And therefore they can have underlying injuries without a lot of outward signs, right? So in an adult, you know, if they've got a big flail segment, then you can probably bet they have some kind of underlying, you know, pulmonary injury. In kids, because their chest wall is so compliant, if you've ever seen cartoons where like Wile E. Coyote gets punched in the chest and his chest pops back out, that's what kids do in a lot of ways. So they can have underlying injury to things like their liver, spleen, lung, heart, and not have the big outline signs that we typically expect to see in adults. They also have a high body surface to surface area to body volume, so they dissipate heat quickly. And so when we talk about kids in pediatric trauma, temperature control really is key, because any kid who's in shock at baseline, if you make them cold, it's going to make them worse, and they will dissipate that heat off very, very fast on even a normal kind of temperate day outside or around. So we talk about needing to control that heat loss and keep them as warm as we can. So we're going to talk about some things that make them different, and we're going to focus on really the primary survey and looking at it through the lens of the primary survey. So every version, there's been 3 different versions of trauma life support. There's been PHTLS, BTLS, ITLS. We teach ATLS to like the EM fellows, residents, and stuff like that. And so whatever version of trauma life support you've taken, they all pretty much focus on that first primary survey, A, B, C, D, E. And so we're going to look at the things that make kids different, looking at the primary survey. And the first is airway maintenance, and with the caveat of using C-spine control. So there's this old notion that kids don't really get C-spine injuries, and we didn't need to worry about C-spine control in kids, and that's really, really false. And we'll talk about that more when we get down to like neurologic injuries and disability. But when we're managing an airway, we always need to do that while having respect for the cervical spine. So airway, the most common cause of arrest and death in trauma is inability to establish and maintain a child's airway. It is the one thing that really kills kids in that second peak that we talked about, is inability to get and control their airway. The larynx is anatomically higher, it's more anterior, their epiglottis is shorter, less flexible, and it's the narrowest point of the airway is actually the subglottic area in the trachea, the cricoid rings, as opposed to the glottic opening in adults, okay? So these are all things that just say that kids' airways are different. They're anatomically different, and it makes intubating them and makes managing their airway a little more difficult, okay? So this is a picture of a little kid's airway. So this kid over here is about probably 4 months old, and you can see that you have these big arytenoids, you have this big floppy epiglottis. If you weren't looking down a perfectly taken picture of the scope, this airway is going to be much more anterior, so you're going to have to kind of get some pressure and some lift to probably see it a little better. You can see how it kind of narrows once you shoot past the glottic opening. And so that's typical of a pediatric airway, as opposed to this kid who's a little older and a little more adult-like. The arytenoids have thinned out, the epiglottis is a little thinner, but you still have that kind of upside down U-shaped epiglottis. Glottic opening is a little wider. Oops. Anyway, so airway is just a little different. I don't know how we went back 3. Okay, airway is just a little different in kids, and it makes intubating them and managing the airway a little more difficult, especially if you don't do it a lot, right? The average paramedic will do maybe 2 to 3 pediatric airways their entire career. And that's probably being a little generous nowadays. It used to be a little more than that when we intubated more people, but we also have just more paramedics running around, right? That are kind of diluting out the number that people get. And so we tend to get a very few pediatric airways. And like any skill, when you don't do it a lot, it's very difficult to maintain that skill. So airway control, again, is our first priority. We talk about A, B, C, D, E for a reason with trauma. Again, beware of the C-spine. Controlled airways recommended for kids who obviously have altered mental status, severe facial injuries, respiratory distress, chest injuries, anything that's going to impact their ability to maintain their airway or their ability to breathe on their own appropriately. So clear the airway. and starting with the BLS maneuvers, jaw thrust and stabilization. Caution when using oral or nasal airways, depending on the kid's mental status. We generally discourage nasal airways in trauma in kids. Remember, kids are very prone to head injury, and we worry always about kids with basilar skull fracture, so we discourage the nasal airways. Oral airways we can use. We do have to be careful with them. We don't want to cause any, if there's damage to the palate or to the face, we don't want to cause more injury. Also, if they still got a gag, we're not going to be able to do that. We got to oxygenate and ventilate them, and then intubation, and then of course, as a very last resort, needing to crike someone. So oral tracheal intubation has typically been considered the gold standard. That's been a problem for us in EMS though. Historically, that's been challenging in the field. Complication rates with pre-hospital intubation of children is reportedly as high as 25 to 30% with pediatric field intubation, okay? So success rates are actually pretty low. In fact, only about a third of pre-hospital pediatric airways end up being successful, and of those, a large percentage end up having some difficulties and some complications. That's why over the years we've moved away from intubating these kids as much in the field. Nasotracheal intubation, again, usually not entertained because of the risk of the high rate of head injuries and risk of basilar skull fracture. And this is where some of the newer airways can be really effective. They can be quickly and easily placed, and they can maintain the airway very well. So when we talk about supraglottic airways like the King tube, the iGel especially, these airways work very well. They're very effective. They're very easy to place, okay? And so we've really encouraged the use of SGAs over the years in kids when we're able to. BLS airways are often encouraged in the field, like oral airways. And in fact, when you compare people with BLS airways and simple bag valve mask ventilation versus kids who have endotracheal intubation in the pre-hospital setting, when you compare their survival rate for trauma, there's actually no difference. So it reinforces this kind of notion that oral airways and good bagging with a good mask seal really is effective at ventilating these kids and can work very, very well. Suctioning and positioning are really our keys to success when it comes to managing the pre-hospital airway. A lot of these kids are going to have some blood, some secretions, but if you think about the average kid, little babies tend to eat every 2 to 4 hours, right? So if you're managing this 6-year-old who was in a car, or 6-month-old who was in a car wreck, what's the chances that that kid isn't going to have some vomit and nasty stuff in their airway because they probably eaten pretty recently as well, okay? So suctioning and positioning are really key. And then the most important thing when managing an airway in a kid and intubating a kid in a traumatic setting is really preparing the patient as much as possible, because we're really worried about two things: hypotension and hypoxia around the period of the intubation. So we really do need to prep our patients as much as we can, more so than in adults. Preparation of the pediatric patient for intubation is absolutely key, and we'll talk about why. So post-intubation hypotension. So if you look at patients who admitted to the hospital who were intubated, if you look at the people who suffered from post-intubation hypotension, so a lot of people, right? So you give them a sedative, you give them a paralytic, then you intubate them, then you start ventilating them, right? So you've given them a sedative and a paralytic, which can alter your blood pressure. But what do we also do? We bag them, which increases your intrathoracic pressure, and that can alter your hemodynamics as well, right? So we do a lot of things that can mess with your blood pressure, on top of the fact that you're at trauma and maybe losing some blood and have some reasons to be hypotensive at baseline, right? So if you look at people admitted to the hospital who had their airway managed, if you look at their people who suffered from post-intubation hypotension, their in-hospital mortality is 35% compared to people who didn't suffer intubation or hypotension with intubation at 20%. So there's a 15% increase in your risk of mortality if you suffer from post-intubation hypotension. Predictors: advanced age, so this was not just peds, but advanced age, respiratory failure, and elevated shock index, okay? So shock index is your heart rate divided by your blood pressure. Normal for an adult is somewhere around 0.5 to 0.7. The numbers for kids are a little different because their heart rates and blood pressures vary by age, right? So a kid who's 4 months old, a heart rate of 140 actually isn't that bad for them, as opposed to if you're 50 and have a heart rate of 140, right? So the numbers are a little different, and you can see the normal age-adjusted shock index for kids down there at the bottom. So the numbers are a little different, but the idea is still the same. If you are shocky pre-intubation and you have an elevated shock index, then you have a significantly increased risk, an odds ratio of 55, to suffer from post-intubation hypotension, and therefore a 15% increase in your in-hospital mortality, okay? So all that is to say is that if your patient is shocky and has an elevated shock index prior to intubating them, the chance that this goes really well is not so good, right? And so we need to prep these patients. We need to, before we start doing things like intubating them, maybe we need to take some time to tank them up, to give them some fluid, to give them some blood, to start correcting that shock state a little bit, because the last thing we want to do is that if we can bag them and manage them and ventilate them okay, the last thing we want to do is then induce some hypotension and increase their mortality rate, okay? So C before A, sort of. We need to manage their airway, but if we can get away with a BLS airway and bagging and ventilating them, then it might be better for us to consider what we call like a delayed sequence intubation, where we kind of put off the intubation a little bit until we can more aggressively manage their hemodynamics and get them to a better physiologic state. And this is especially true in head injuries. So if you look at head injuries, which we all know kids are super prone to head injuries, right? Because they have big bobbleheads. When they get ejected from cars, when they fly around cars, that head leads first, right? So kids are really prone to head and neurologic injury. So in one study, and this is mixed adult and pediatrics, they looked at 717 patients with severe TBI, meaning GCS of less than or equal to 8 on presentation, and therefore all required airway management. If they had a hypotension around the period of intubation or hypoxia around the period of intubation, so a blood pressure systolic blood pressure of less than 90 or a SAT less than 90, if yes to either one of those things, they have a 150% increase in their mortality, okay? 150% increase in mortality. And this makes sense, right? Because we know that cerebral perfusion pressure, the pressure that gets blood to your brain, is dependent on two things: your mean arterial pressure and your intracranial pressure, right? So if your intracranial pressure is already elevated because you have bleeding in your brain or a significant head injury, if you drop your arterial blood pressure, meaning your systolic pressure, basically, your MAP, then obviously we're not perfusing your brain as well. So that worsens your secondary injury from your TBI, right? So you have two kind of parts to your injury in a TBI. You have the initial impact that creates the bleeding, but then you have the secondary injury that's created by things like hypotension, poor perfusion, hypoxia, things that worsen that injury. We talk about secondary injury a little bit in stroke and other stuff. The same thing's true in TBI. And so if you have yes to either hypotension or hypoxia, 150% increase in mortality. Okay, so for kids who are frequently intubated due to a head injury, getting their SATs in a good place, taking the time to optimize their hemodynamics, to tank them up, to help get that blood pressure up before we intubate them can be key. Now, I'll grant you there's going to be the kid whose SATs you can't maintain, who you can't always bag, who you just have to occasionally go for it on, right? But if we can bag these kids, which again, most studies tell us that we should be able to bag them up a little bit with an oral airway and good bag valve mask ventilation with a good seal, then maybe we need to think about delaying that intubation a little bit to optimize those SATs, to optimize those hemodynamics so that we're not increasing our mortality rates, okay? So talking about intubation in kids for trauma, we need prepping patients is paramount in pediatrics, okay? Far more than it is in adults, because kids who are frequently have head injury as their reason to need intubated for trauma really are sensitive to these things, and really we need to avoid a bad physiologic intubation or physiologic situation where we're intubating somebody in a bad way that's going to increase their mortality by either having that post-intubation hypotension or hypoxia around it, okay? So I need to optimize our hemodynamics with volume repletion. We can consider push dose pressors and have those ready to give. This has been done in anesthesia for hundreds of years. It's finally catching on in emergency medicine and now in EMS with, push dose pressors given kind of during that dip in their blood pressure immediately after intubation. And we need to choose our meds carefully, right? So we want to be careful about what meds we choose. So Versed, propofol, things like that tend to significantly affect kids by dropping their preload. And they have a lot of hypotension associated with those drugs, more so than adults do. So things like etomidate, that's a little more hemodynamically neutral. Ketamine, we have easily accessible in the pre-hospital setting and we love. There's this old notion that you shouldn't use ketamine in head injuries. Please forget that anybody ever taught you that. That has never been proven to be a problem. Some old neurosurgeons still cling to that dogma, but I can promise you it's going to be okay. So we want to pick things that aren't going to make a bad situation worse. So avoiding things like the Versed, propofol, and benzos, which cause significant hypotension in kids, is important. And then we talked about optimizing them, and not just optimizing the hemodynamics, but again, optimizing our oxygenation. So non-rebreathers, bagging them up as we can, apneic oxygenation during intubation, right? So putting a cannula on the kid's nose and just cranking it up high, right, while we're intubating, that creates kind of a passive oxygen reservoir, reduces the rate of hypoxia during intubation from 29% in kids to all the way down to 7%. So utilizing apneic oxygenation during these intubation attempts can be also key. And then again, we can elevate the head of the bed, which also can help our oxygenation a little bit. So doing things that we can do to optimize these kids, to really prep them for the intubation, because again, we don't want to increase that mortality doing things that we need to do, right? Click to edit master tile, that should have disappeared. Anyway, okay. So, and then of course, the big thing too is you got to get the tube in, right? So ways to increase our first pass success in intubating kids. First attempt success rate in difficult airway characteristics is always increased with a bougie. If you don't have bougies in your agency, you need to have bougies, okay? This is probably the greatest airway tool to come along, maybe ever. I would almost put this above video laryngoscopy almost, okay? These things are amazing and they do their job and they do them well and they are cheap and they never expire. Well, I guess technically the packaging isn't sterile after like 2 years or something, but they're cheap and easy to access. And in fact, among all patients, difficult airway and not, first pass attempt success rate is increased with a bougie. The median duration of your first intubation attempt does not significantly differ. Hypoxia doesn't significantly differ. So it's not like using one slows you down or anything like that, okay? And in fact, combination of bougie with video laryngoscopy, looking at the emergency medicine airway database, has the highest rate of first pass success in emergency department intubations, from 82% up to 96%. Combine this with the salad technique that Wes loves to talk about a lot, where you suction these kids' airways and decontaminate it when they've got nastiness all in there. Really high rate of success, first pass success intubation. And they actually do make pediatric size bougies and they'll take down to a 4 ET tube, okay? So that's gonna get you most kids outside maybe the little itty bitties, okay? So bougie and video laryngoscopy, if you have it available to you, really significantly increase that first pass success rate, okay? And I use bougies on all my intubations, period, end of story, right? Because yes, there are plenty of intubations I do on a routine basis in kids that are simple, right? But I don't want to be practicing with something only on the crappy ones, right? Because you get your practice and get good at your skills when it becomes routine, right? That's why we're great at managing chest pain and STEMIs, because how many chest pains do we run through stuff? Pretty low suspicion that it's MI, but we are so well practiced at the routine of what to do, 12 leads, oxygen, nitro, aspirin, morphine, IV, blah, 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 in chest pains, that when it is the massive STEMI, we're good at it. We've done it 100 times, right? So I recommend using them on all your intubations, because the time you don't want to be practicing and playing with something you're not used to is the crappy time, okay? These are great tools. All right, yeah.
Hey, Doc, we've had a couple of questions come in. So question number one, could you talk a little bit about cuffed versus uncuffed tubes for pediatrics? And number two, about transport decisions to Children's Hospital with trauma patients for pediatrics. who may have a difficult airway. In
Yeah.
other words, the decision to not stop at a closer hospital.
Yeah.
Or to stop.
Cool. So cuff versus uncuffed tubes. Please throw away your uncuffed tubes. I finally thought I had beat this mentality out of everybody, but maybe I just need to do it a little longer. There is no reason to ever put an uncuffed tube in a patient, end of story. This dogma that still exists in the paramedic textbooks and on the National Registry exam, although I've told the National Registry is finally going away from this too. So praise Jesus, maybe we're making some impact. But the dogma that uncuffed tubes, somehow the balloon of that cuff was going to necrose the trachea of kids has never been proven. The last time I used an uncuffed tube was a resident intubating NICU babies, okay? We don't even have, we have them. They're tucked away in a special area where nobody can get to them, uncuffed tubes in our trauma bay. Because again, uncuffed tubes present a lot of advantages for us in the field, right? So the most common complication, aside from esophageal intubation or pre-hospital intubation, is tube dislodgement. And the balloon gives you a little bit of resistance to try and help prevent that. The other thing is, again, these kids are bleeding in their airway. They probably have a full belly if it's a little kid who's fed recently. And the balloon better seals the airway to prevent aspiration and crap from just getting in the airway. The other thing is we tend to undershoot tube sizes in kids in the field. And the balloon helps make up the difference a little bit, right? Because the last thing you want to do is you successfully intubate somebody, but then you use a tube that's so small they have a massive air leak and you still can't ventilate them well. So balloons present a lot of advantages, or cuffs present a lot of advantages for us in the pre-hospital setting. We need to make the uncuffed tube mentality go away. They need to be gone. So always use a cuff tube. Now, if you're listening to this and you're about to take your National Registry test, the test answer is an uncuffed tube. In the real world, you should never, ever, ever use an uncuffed ET tube. And then what was the other question? Oh, if you need an airway or not. Yeah. So that is sort of an in-the-moment decision. If you can maintain the kids' oxygenation and you can ventilate them well using basic airway techniques, whether that's a supraglottic airway with like an I-gel, which I would argue most people do not need an ET tube if you can get an I-gel in them, at least not in the immediate setting, or you can bag them with a good BLS airway and ventilate them effectively, then I would argue you are much better served by going straight to the level 1 pediatric trauma center. If you cannot maintain their airway and you cannot ventilate them, then that is a cannot intubate, cannot ventilate situation, and that's an emergent airway that needs done as soon as possible. That's when you make the pit stop, okay? Make sense? All right. All right, primary survey B, breathing and ventilation. So assessment of the airway we've done, assessment of breathing, exposure, rate, inspection, auscultation, and then really the big one that we sometimes tend to forget is making sure we have symmetry and presence of breath sounds on both sides, right? So kids have really compliant chest walls, but their underlying lungs are a little less compliant, okay? So we can overbag them and cause pneumos. But the big thing, remember we talked about, they have really soft chest walls, right? We talked about how they're like Wile E. Coyote. They can have pretty significant underlying pulmonary injuries, including things like pneumothoraces, without a big, like, obvious broken rib segment. And we want to make sure we're not missing pneumothoraces, right? Because kids, the things in their mediastinum are not as fixated as they are in adults. They can move things, or things are a little more mobile in their chest. So kids who develop pneumothoraces are more prone to developing tension physiology more quickly than adults are, okay? So again, an intact airway does not assure adequate ventilation. We need to make sure the kid's breathing and breathing well. Just because we look at them and go, airway's good, that doesn't mean you're necessarily ventilating well, right? So signs of respiratory distress, you guys know all these: tachypnea, belly breathing, retractions, nasal flaring, stridor, wheezing, all the noises. So blunt chest wall and prominent pulmonary trauma are common in kids. Again, they have more compliant chest walls, so they can have underlying injury without a lot of evidence on the outside. We talked about that. They can have flail segments when they do have them with less ribs involved. So when we talk about adults, we tend to talk about flail segments. We talk about like 3 ribs usually-ish. Kids can have them actually with 1 or 2 because of their different chest wall anatomy. Major vascular injury is uncommon though. So the beauty of having things more mobile in your mediastinum means you're a little less likely to like rip your aortic root and do things like that, like adults are. Pulmonary contusion, pneumothorax, hemothorax, rib fractures are the most common injuries. So looking at chest x-rays, this kid has a big old pneumo over here. That one's pretty hard to miss. And the big hemothorax on the other side. All right, so there's not a lot about breathing. You guys know how to ventilate people, right? So this one's pretty easy, right? So if they're breathing well, and this is where end-tidal CO2 can come in really handy, right? So we tend to not throw trauma patients a lot on end-tidal CO2, and that's probably not what we should be doing, right? So especially where kids, right? So kids can breathe 8 times a minute in shallow, and their SATs may be okay, but just because you're oxygenating and your airway's intact doesn't mean you're ventilating, right? They're still not breathing well. They're still going to stack up that CO2. So end-tidal CO2 is really useful to monitor their CO2, right? Because CO2 is what tells you whether somebody's ventilating, right? Not just whether they're oxygenating. So end-tidal for some of these kids, especially if they've got some chest injuries, can be really useful for help us assessing the status of their ventilation and knowing whether or not we need to be ventilating them, as in taking over that breathing and bagging them, right? So ensuring that they're looking for signs of respiratory distress, being sensitive to those signs, making sure that we've got them on oxygen, and then whether or not we need to be ventilating them, okay? All right, circulation and hemorrhage control. So things that we can look at for kids for signs of their circulatory status, heart rate, right, pulses, not just presence of, which is really, really important to know, by the way, but also strength of the pulses, where we can find them. I'm a lot more worried about the kid that I can only find a femoral in than the kid that I can get good, strong radials in, right? So not just necessarily pulse presence, which is important. And I say presence sort of as a joke because, you know, it's funny, but the reality is the most common traumatic arrest rhythm for kids is PEA. So the people who hook the kid up to the monitor and are staring at the monitor the whole time and never check an actual pulse, this is where you run into trouble, okay? This is why I yell all the time at people to treat patients, not monitors, okay? If you pull my peds emergency medicine fellows in the room and you ask them what's the one thing I have yelled at them for in the middle of the ER, every one of them will look and say, treating the monitor. Because what do? They walk in the room and they stand there and not his hand on the patient and they look at the rhythm and they look at the SAT and they look at the, I'm like, well, did you touch the patient? No? Well, all right then. How about you're done here today? So treating patients, not monitors. So again, PEA, as kids go into shock, the first thing that happens as they become hypotensive and decompensate and start to arrest is their heart rate starts to drop. They slip into a PEA and then they lose their pulse. And that, well, they've lost their pulse. They go into a PEA before they progress into asystole, sorry. So again, this is the time you got to just not check an actual mechanical pulse, especially in these kids, especially if you've seen any changes in their status. You've always got to correlate what you're seeing on the monitor with an actual mechanical pulse. And you'd be surprised how little that necessarily happens today, okay? And I blame the National Registry and the static cardiology station that they taught us for hundreds of years on that, but that's a different story. Perfusion, capillary refill. When I took care of adults, I sort of laughed about capillary refill because I thought it was really stupid and it was a box on the PCR. So I was like, oh yeah, it's like 3 seconds, cool. Because it's kind of useless. For kids, capillary refill is actually really important. So kids, we'll talk about shock in kids in a second because it's really important. Outside of an airway, the thing that really kills kids is shock. Okay, and so shock is incredibly important to recognize and to manage aggressively in children because once they start to decompensate, you have a very small window before they arrest. But capillary refill, because kids only have a couple of ways that they can compensate for shock, capillary refill is actually really sensitive because one of their big compensatory mechanisms is kids have at baseline an increased peripheral vascular resistance, and they are excellent at shunting blood. They can shunt blood really, really well. And capillary refill will tell you whether that kid is shunting blood or not, okay? It is really reliable in kids. In fact, I told you I complain about my fellows, but the first thing I do when I walk into most bad traumas or resuscitations, if I'm not immediately at the head having to manage an airway, is I'm actually at the foot of the bed touching the kid's foot. Because if I can get a cap refill and a pedal pulse, then I'm probably living in a pretty good place. But if I can touch that foot and it's cold and that pulse sucks and their cap refill sucks, then I know I got things I need to get done, okay? So capillary refill is actually a really useful tool in kids, despite the fact we kind of laugh about it in adults sometimes, okay? The kids' color, are they pale, are they blue? How they're acting when kids go into shock, their first thing they do is they start to get kind of fussy, and then they start to get really sleepy, okay? So how they're acting, their sensorium, their blood pressure. I grant you blood pressure is not always 100% a great thing, right? Because it's really hard to get in these little babies. Most of us don't have a cuff for it. They kick around, they scream, they mess with it. It's hard to get. I get that. And plus, kids can be in shock despite having a normal blood pressure. And we'll talk about that more in a second. And then if we're feeling so inclined, urine output's actually a great marker of shock in kids. All right, so altered vital signs. Tachycardia, the earliest, most important, most under-recognized sign of shock in kids, okay? If I teach you one thing about shock in kids, period, whether it's medical or trauma, it is that kids can be in shock despite having a normal blood pressure and being relatively well appearing, okay? Anybody who's heard my big, kids medical management of the sick critical kid shock talk, that is like the first thing I talk about, okay? So here, kids can be, again, in shock despite a normal blood pressure. We are taught from day one as EMT basics all the way through paramedic that shock equals high heart rate, low blood pressure, okay? That is branded into our brains like nothing else in this world ever is, okay? It is absolutely false for kids. Now, a kid who has a high heart rate and blood pressure is in shock, yes, but they don't have to have a low blood pressure, okay? Kids compensate really, really well until they don't, and we'll talk more about that in a second. Tachypnea, narrowed pulse pressures, so when that systolic and diastolic start creeping together. Hypotension, very, very late finding. By the time a kid is hypotensive, you're kind of screwed, and we'll talk about that more. And then physical findings, again, cool pelvic extremity, delay cap refill, and we already talked about their kind of altered mental status. Children are adept at compensating for blood clots. Tachycardia is an early sign of compensation, but it may be subtle. Depressed mental status, again, is the earlier sign. They get initially a little fussy, and then they quickly progress into being a little sleepy. Perfusion is cap refill is an excellent monitor for their circulation. And again, hypotension is a late sign. So here's why. What is the super simple definition of shock? You're not getting blood where it needs to go, right? We can talk about inadequate in-tissue perfusion, blah, blah, blah. The simple pediatrician term of shock is you're not getting blood where it needs to go, right? If you're not getting blood where it needs to go, you have to move blood better, right? Simple enough. So you have few ways of doing that. You either shunt blood, which we talked about kids are great at, okay? You increase your heart rate, or you increase the amount of blood you're pumping with each beat, right? Okay, so if you think back to cardiology and you think about like the Frank Starling curve and increasing heartbeat efficiency and more blood and stroke volume and all that crap that nobody really remembers and everybody tries to forget, okay? Kids can't really do that, is the end result. Kids' hearts already beat so incredibly efficient at baseline, their ability to pump more blood with each beat is just not there, okay? The average EF for a kid, especially a little baby, is upwards of 75%, okay? When your heart beats, conversely in normal adults, like people say 2/3, so around 60-ish%, okay? When your heart beats so efficiently, you can't pump more blood very well. Okay, so kids really are down to two mechanisms: their ability to shunt blood, which they really quickly will do and kind of max out, and then it comes down to their heart rate. And that's why kids do well with shock until they don't, because kids have incredibly healthy hearts, and they can jack their heart rate up, and they can very adeptly compensate for that shock state with just their one leftover compensatory mechanism. Okay, so if you look at this chart, the top green line is heart rate, the blue or black, I guess, middle line is blood pressure, and the orange line is cardiac output. Percent blood loss is on the bottom, and percent normal is your y-axis, okay? So what you'll see is this kid's heart rate is going up, 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 up. Here we are at 15% blood loss, 25% blood loss, so a quarter of my blood is now outside my body, right? And you'll notice blood pressure is pretty much exactly the same, okay? Even kind of right here at like 30%, your blood pressure is still really the same. So a third of the kid's blood volume is outside their body, but they're still maintaining a normal pressure, okay? Now, who thinks that kid is not in shock with a third of their blood outside their body, right? The kid is in shock, but they're so adept, their heart rates can manage that so well, and they're so adept at compensating with shunting blood and jacking up their heart rate that they're still managing to maintain a normal blood pressure, okay? Now look what happens though. They sort of max out that one mechanism, right? Their heart rate has sort of gotten to where you can't get it up much higher. And look what happens to this blood pressure now. We pretty quickly start to tank off, right? And look how quickly, so right here, the heart rate is going down. What's that? That's your patient arresting, right? So look how long we had before we dropped our blood pressure. And then look how short we have from my blood pressure is finally showing signs of shock or changing to I'm dying, okay? And that's where this notion that kids do great until they don't, or they compensate until they fall off the cliff comes from. Because their heart rates and their ability to shunt blood, but mainly their heart rate, they can compensate for that blood loss up until the point they don't. And then you have a very, very short window of time once they finally are in shock. They were always in shock, but they now have the high heart rate and low blood pressure. You have a very short time once that happens before they die, okay? And that's why I say kids can be in shock despite a normal blood pressure, okay? Because kids, tachycardia, pay attention to a kid's heart rate, because I guarantee you this kid has a high heart rate, they're probably breathing funny, and I guarantee you their cap refill sucks, okay? So all signs that that kid, even though their blood pressure is normal, is in shock and alerts you to the fact that you need to aggressively manage that kid, right? So why are they in shock? Hemorrhage is responsible to 20 and 40% of all pediatric trauma deaths, okay? We got to stop the bleeding. That's not always easy because sometimes it's internal, but if it's external, we can. Remember that blood volume is different for a kid, right? So remember, blood volume is dependent on your size. So kids have lower relative circulating blood volume than an adult does. So if I lay out a pint of blood on the ground, no big deal, right? I can go to the Red Cross and I can donate a pint of blood and they give me my cookie and my orange juice and they send me home, right? But if you are a full-term infant and you weigh, 8 kilos with your 80 mLs per kilo of circulating blood, that pint is a much bigger deal for you than it is for me, right? So again, smaller volume. So blood loss is relative. And so what appears to be small volumes can add up quickly. Again, 200 mLs in a 10-kilo child is 20% of their blood volume. So if I look at Wes and he, cuts himself and has 200 mLs of blood on the floor, I look at Wes and go, yeah, you'll be fine, put some pressure on it. But if the kid is 8 months old, now we're starting to approach that point on that graph where that blood pressure is tanking and we're not living in a good place, right? So blood loss is relative, and even what appears to be small can add up quickly and be critical for a little kid. Just keep that in mind when you're assessing and looking at the amount of blood, okay? Sources of shock in the chest, you can get tension pneumothoraces. They can bleed into their chest, pneumothoraces. Pelvis, kids can lose a lot of blood from their pelvis and from long bone fractures, okay? Femurs and little kids will lose a lot of blood that way, okay? So looking at their pelvis, looking at those extremities, because kids can bleed a lot from that. Abdomen, kids have big Buddha bellies, right? Especially little babies. So they're really prone to intra-abdominal injury, spleen, liver, bowel injuries. So look at the patient. Are they bleeding? If there's something exterior, we know what to do with that. If it's interior, if they have a big belly, if their belly is distended, if it's tender, if they've got a big, section, big flail, big bruise over their chest, even if there's not a big flail segment or obvious broken ribs, think about, is there a pneumo under there that I need to deal with, a tension pneumo that I can decompress to help fix their obstructive shock and fix their circulation problems. Early vascular access is important. 1 peripheral IV for sure, 2 we love. Intraosseous lines early, okay? We have sort of gotten to this place where we're like, ooh, I don't know, is he really sick enough for me to want to put in an IO? And somehow IO is viewed as this like horribly barbaric procedure. Guys, you can go on YouTube and find videos of people drilling themselves, okay? It's really not that bad. And remember, and if the kid is in shock, IO is a category A procedure, okay? And so if you have a kid who's sick, who's shocky, please put their IO in. Like if you can't, vascular access is hard in these kids, right? Because we talked about they have increased peripheral vascular resistance at baseline. They shunt blood really easily. If they're already in shock and have a little bit of vascular collapse, how good or how quick can we easily put in a little 24 gauge IV into the hand of the 6-month-old who's already shocky and shunting blood, okay? It's not easy, all right? So rely on the tools you have because early vascular access and resuscitation of these kids is paramount. And it's one of the biggest things we can do outside of managing that airway that really makes a difference in that second peak that we talked about we want to treat, okay? Fluid challenge, crystally fluid, LR or normal saline. We're sort of on this kick of getting back to LR these days. And anybody who's done this long enough knows this pendulum has swung like 9 times now. But now we're back on an LR kick. So, but whatever, use what you have, okay? 20 mLs per kilo. If they have an inadequate response, you can repeat another 20 mLs per kilo. If you're still poor response, if you're one of the places that are carrying blood now, and there's a few out there, you can go ahead and give them some blood, 10 to 20 mLs per kilo. We normally stick more on the 10 side for a first initial bolus of blood. If they are unresponsive at that point, remember to think also about neurogenic shock, right? Because kids are really prone to head injuries. They're fairly prone to cervical spine injuries. And so if they're, remember the basic definition of neurogenic shock is basically fluid unresponsive shock, right? So if you're doing all this and you're still not getting response and the kids had signs of head, neck injuries, remember to think about neurogenic shock because that's when we need to be aggressively early starting pressor therapy, right? Because we can give them blood and fluid all day. It's not going to make any difference, okay? So fluid boluses, at least 1 or 2 if they're hypotensive or they're tachycardic and with poor cap refill, signs of shock outside of hypotension, because again, kids can be in shock despite a normal blood pressure. Think about blood early if you can, and then consider neurogenic shock if they're still not getting better after that. What's up, Wes?
Hey, Doc. So one question is, there's been a lot of talk recently about permissive hypotension for hemorrhagic shock in adults. So how does that apply to kids?
Yeah, we don't love that in kids. Now, to a certain extent, it is okay. I think part of that, there's some nuances to me saying we don't like that, but the reality is because by the time kids start to become hypotensive, you are so far behind the 8 ball in managing their shock and heading for a bad place so quickly that we don't love permissive hypotension in kids. We tend to be much more aggressive with treating shock in kids because once they get hypotensive, things start to go downhill so quickly and so fast. We don't really love that theory. Now, if the kid is, not super tachycardic and pressure's maybe a little low, okay, maybe, but we don't really love the idea of allowing hypotension in kids because again, they can maintain a normal blood pressure so well that by the time you get there, it's just, you're not living in a good place. So we tend to more aggressively treat kids for shock because if that heart rate's up, their cap refill sucks, we really don't care. We treat them pretty aggressively because we don't want to end up on the wrong side of that graph.
So the other question actually comes from Dr. Ferguson, and
Thanks, Will.
You may be getting to this later in the lecture, but he wanted you to speak a little bit about backboards in kids, since we've really gotten away from backboards in adults, except for signs of paralysis or
we're getting there. That's under the D part.
Okay, all right. Sorry.
All right, so now to D. So rapid brief neurologic assessments, spinal precautions, and by spinal precautions, we don't necessarily mean backboards. We'll talk more about that in a second. Rapid assessment of their GCS, their level of consciousness, and then assessing their pupils. Those are probably the 3 things that we really need more than anything else. Those are the kids that, I don't know, do I just click the X? Hey, should I just click the X? Okay. Woohoo, fixed. Okay. So quick rapid assessment of their level of their neurologic status. Assume all trauma patients, even kids, have a cervical spine injury. All right. So there used to be this sort of old notion that kids really didn't get cervical spine injuries. And the truth is that kids do suffer cervical spine injuries. They just are different than adults. We tend to talk less about like fractures in kids, and we tend to talk about what we call subluxations, where kids kind of have either ligamentous injuries or slipped vertebrae. And we'll talk more about that in a second. But backboards, if the condition mandates, we definitely don't love backboards in kids any more than they do in adults. Backboards have been shown in kids to worsen their shock state for like penetrating injuries and stuff like that. So just for the same reasons adults have gotten away from them, we have two. The protocols still, I think, say that like if there's concern for spinal injury, then you're still supposed to use one. That's fine. But we feel the same way about backboards in kids that you do in adults. They are not necessary all the time. But we still do want everybody in a C-collar the way you do in adults. So your younger children have cervical spine column injuries can be pretty common. Older children tend to be more like adults. Children are more likely to have spinal cord injuries without fractures, which we talked about. And properties of pediatric spine disposing them to injury. We'll look at the picture here. So this is a lateral neck film. This is a lateral C-spine image of a kid's vertebrae or cervical spine. What you'll notice is these vertebrae are kind of wedge shaped, right? So they kind of look like that because they're very anteriorly wedged. Also, you have two ligaments that sort of hold your cervical spine in place. You have your posterior and your anterior spinal ligaments, right? And those, turns out, they're not super hard and fibrous yet in kids. They're still really flexible, okay? And then the facet joints that sort of hold this stuff in place, turns out those groove in and kind of get set as you age, and they're not so much that way in kids. And then what's on top of that unstable structure? A big bobblehead, right? So kids have big bobbleheads. So basically you've taken this unstable structure and put something that accounts for like 30% of their body mass on top of it. Doesn't seem like a great design. Any engineer would have a meltdown at that, okay? So all this is to say that while kids don't necessarily fracture their cervical spine, what they'll do is they'll slip a vertebrae and sublux one, or what'll happen more so is that cervical spine shifts and then comes back. And so they end up with a spinal cord injury and a ligament injury without having a big old obvious fracture or even subluxation. So kids do get cervical spine injuries. They're just different than adults. So cervical spine immobilization is still important in kids, just as important as it is in adults, okay? Head injuries, we've already sort of touched on this when we talked about Airway. Kids are really prone to head injuries. It's the leading cause of mortality and long-term morbidity and trauma for kids. Falls, MVAs, I swear in this state, ATV needs to be moved to number 1. Bicycles and assaults. They are different from it. So kids' brains and heads are different from adults, and they contain more water than the immature adult brain. So the brain is a little less compliant, which is why a little bit of bleeding makes a big difference. It has a higher rate because they're so dependent on good cerebral flows and their neurons are so sensitive. They have a higher rate of basically just metabolic acidosis and cell death when they start to have brain swelling and increased ICP. And that's why we get a higher mortality rate in kids. All right, the keyboard decided it hates me. All right, so head injury, we talked about this earlier. Primary injury, that's the immediate damage from the trauma, contusion, shearing, blood. The secondary injury is the inadequate delivery of oxygen and nutrients to the brain, and that's where we can make a difference, right? We talked about that with Airway and how we're going to tank these kids up, how we want to manage their airways. But the idea is also that we need to prevent that going on. We need to do good ongoing monitoring. We got to maintain their blood pressure. We got to maintain their oxygenation. We want to prevent any sort of secondary injury that we can. Avoiding hypoxia and hypotension. We talked, it's like the 4th time I've mentioned it, so just for good measure, I'll say it again. Avoid hypoxia and hypotension. management of their airway. Remember, your cerebral perfusion pressure, the pressure that your brain is getting blood, is dependent on your MAP and your ICP, okay? So you got to make sure their blood pressure is in a good place. You got to treat that mean arterial blood pressure. But what happens when the ICP gets too bad? It doesn't matter how good your MAP is. If your ICP is going up, your brain is getting displaced, you're starting to herniate, it doesn't really matter. So when we talk about herniation, we talk about these kids who are in a bad place, we talk about the Cushing's triad, right? And so that's hypertension, bradycardia, and diminished respiratory effort, okay? It's sort of the triad of your brain is herniating and you're trying to die. So what can we do acutely to sort of reverse that? Well, we can elevate the head of the bed. We can give them hypertonic saline if we have it. We can give them mannitol, and we can briefly hyperventilate these kids. And I say brief because there used to be this notion that we would hyperventilate all these head injuries, and we bagged them at like rates of like 40 the whole way to the hospital, right? And so turns out that prolonged hyperventilation actually makes head injury worse. Because eventually what happens is you drop their CO2 so much, they actually get vasoconstriction of their cerebral vasculature, and that actually decreases their cerebral perfusion pressure. And so when I say hyperventilation, that is a brief period of hyperventilation for the kid who's emergently, imminently like herniating and trying to die. So you can hyperventilate them. It will do its job of dropping their ICP, but it's not something you want to do over the long term. It is a temporizing measure to do briefly. And then sedating and paralyzing them, barbiturate comas, other stuff you can do to help drop that ICP emergently. And then E-exposure, this one's pretty much the same for kids and adults. You got to look at your patient, all right? You got to find the other injuries. Same, just like, you know, your national registry test, if you didn't roll them, there was going to be something on the back. Same idea exists here, okay? Take the clothes off, look at them front and back. The big thing with kids is remember to cover them back up and prevent hypothermia. They are much more prone to dissipating heat, losing heat, and worsening their shock state than adults are. So once you uncover these kids, you can't just leave them uncovered, naked, and hanging out on the stretcher, okay? They gotta be kept warm. Otherwise, it's gonna make everything worse. Pediatric injury patterns, we talk about Waddell's triad of injuries. So these are the kids who get hit by the car. So they get the long bone fracture from the impact. As they go up over the car, they get the chest injury / blunt abdominal injury. And then once they're thrown, they end up with the third head injury. So the kid that's got a big old like femur fracture and a head injury, there's something in the abdomen and chest. You just got to find it, okay? The bicycle injury, so they end up with two injuries. They end up with the handlebar in the abdomen and they get bleeding. And then as they go over the handlebars and hit their head on something, they end up with a head injury. So the kid who went up over the handlebars that's got a big old goose egg on their head, there's something in their belly, I promise you, okay? Every time. So back to our case, this is the kid we talked about at the start of this. Looking at those vitals in that exam again, hopefully now that we've talked about some of this stuff, some of the things that we want to do and manage this kid have become a little more obvious, right? And we've thought about this a little more. So thinking about this kid whose heart rate is 68, you know, this kid's 2 years old with a heart blood pressure of 140. Do we think that's hypertensive? Yeah. So we've talked about Cushing's triad, right? So respiratory rate of 8, so low rate, respiratory rate, low heart rate, but a high blood pressure. That's a kid whose head injury is pretty significant, right? This kid's herniating and trying to die. What do we think about this stat? We want to go ahead and intubate this kid at 80? Probably not, right? What's some other things that we need to think about now that we've talked about this stuff? So we've got some bruising over our chest, but no obvious crepitus. Doesn't mean there's no underlying chest injury, right? Deformity over the left thigh. Kids can lose a lot of blood through their femur, okay? So hopefully some of these things, now that we've talked about them, you know, this looks a little less scary, and some of these things that need to be principles to manage this kid by are a little more apparent that we've talked about, okay? So we want to start by getting this kid ventilated, right? We want to get those SATs up while we're starting, you know, lines and fluid resuscitating them, and then maybe come back and do that airway, right? And we might want to hyperventilate this kid just acutely to sort of get that ICP down. If we've got hypertonic saline or mannitol, good time to start thinking about giving that once we get that line in, right? Because we need to bring down that pressure, okay? And then we want to aggressively make sure we're keeping that kid in a good place, watching their hemodynamics, watching their ventilation, watching their oxygenation throughout the transport, right? Because the last thing we want to do is worsen secondary injury, okay? All right, big decisions, where to go. We sort of talked about this already because somebody asked a question about it. You want to get this kid to a trauma center, preferably one that's equipped to deal with kids. There's only one level 1 peds trauma center, which is Children's. Huntsville and USA do see kids. They take kids. And those really but you got to go to, this kid needs a trauma center and they need it pretty quick because somebody's going to have to do something with this kid's head really rapidly. All right, we'll skip over burns today. All right, any other questions?
Hey, Doc, we got one question that seems to always come up every time we talk about peds and transport decisions. So, and it has come up here at Centerpoint Fire recently. So we got a 13-year-old that weighs 250 pounds that's been in a bad MBA.
Yeah.
Yeah, they go to UAB or they go to Children's and
They come to us until they're 15.
So is the age?
It's the age, 15.
Is the hard cutoff, not the weight?
Correct.
Okay. All right. Fair enough. Appreciate that. I had one other question on when we're talking about vascular tone in kids and how they can shunt blood and vasoconstrict so easily and reliance on cap refill. Just maybe mention the effects of pressors on that. So after you've given push-dose pressors, then what should we expect to see? I mean, will they stay vasoconstricted for a longer period of time and more profoundly after they get some push-dose epi, for example?
Yeah, so they can. Usually, though, once they start to perfuse better, you'll actually see you will see them start to improve. You'll see their cap refill start to improve, but that can take time. The thing we tend to watch is hopefully bringing that pressure up, but also that heart rate down. So conversely, you would think as soon as you give them epi, that heart rate jacks up. And actually what ends up happening is it kind of goes up for a little brief time, and then it starts to more normalize because they actually are perfusing better.
Got you. Well, hey, great lecture. Thank you, Dr. Duerring. We're going to take a few minutes of a break. A couple things to mention. One, everybody remember that this week is Emergency Telecommunicators Week, so find a dispatcher and thank them. They do great work for us. They're part of the system that we can't do without. Also remember to please fill out an attendance certificate for today's session, even if you don't particularly need or want the certificate. It really helps us track attendance and has an opportunity for you to give us feedback so we can make this training better. The way you do that is you click the link in the chat box. The password for today's class is pathogen, PATHOGEN. If you're in class or if you can't get to the chat box, you can send an email to alabamaemschallenge@gmail.com and get an automated response with a link to the attendance form. So everybody stretch your legs a little bit. We'll be back in about 5 minutes or so. Hey everybody, welcome back. We're going to get started with Dr. Taylor Payne. He's got a lecture for us today on infectious disease. So is your mic on, Doc? You got the green light?
Not yet.
All right, there we go.
There we go, test it. Hopefully y'all got me now. So, okay guys, so we're going to talk about infectious disease. Infectious disease is a very broad topic. There's a lot of different subsections you can go into. I'm going to kind of breeze through some of the things I thought would be important for the pre-hospital world and talk about some communicable diseases that I thought could be important. But if there's anything at all you want me to delve into deeper, I'd be glad to, just because I'm going to really just touch the surface on a lot of these topics. And then I know there's some specific COVID-19 questions we'll get to at the end as well. So we can go ahead and start talking here. So we're going to talk about types of transmissions of infectious diseases, specifically communicable diseases or diseases that can be transferred from person to person. Some items of when to suspect a disease that can be transferred and when to use what specific PPE and different protocols. We'll talk about some of the more common diseases that are communicable that we could see that would be important to know for the EMS world, different occupational exposures to bloodborne pathogens, and then any ID lecture is not a good lecture without talking about sepsis, so we'll talk about sepsis at the end as well. So just in general, an infectious disease is any invasion of a host by a disease-producing organism, whether it's bacteria, viral, protozoan, fungus, it could be anything. And then a communicable disease is one that can be transferred from one person to another, and this is of great importance in the EMS world when we talk about PPE and trying to prevent these diseases from being or transferred to one or the other. So there's different modes of transmission. There's contact, which you also hear droplet. You'll hear droplet precautions. That's under a subset under contact. Airborne, vector-borne. We'll talk about each one of these further. A common vehicle, which you'll see in contaminated food, such as E. coli, salmonella, things like that. And then blood-borne, which we'll talk about as well. So direct contact or contact transmission can be divided in different categories. Direct, which is actually coming in contact with infectious material directly from person to person. This would be STDs, biting, kissing, anything like that. And then there's also indirect, which is some of the bodily fluids is on an inanimate object, and that's then touched at a later time. Now, each virus or bacteria will have different times that it can survive on these inanimate surfaces. So that can kind of change in regards to how long they can be transferred through this contact transmission. Some of the examples is, of course, HIV, your hepatitis, which is also bloodborne, MRSA, and then some of the other more common upper respiratory infections as well. So a specific form of contact transmission is droplet transmission. This is, of course, been come under wide scrutiny with COVID-19 recently. It's a type of contact transmission. It's basically large droplets with the viral particles themselves that are basically eliminated by the body, either sneezing, coughing, and then those can float in the air, usually very briefly and not over a long distance. So that was kind of the whole, 6 feet apart rule. That was in trying to prevent this form of transmission. They'll be propelled and deposited on mucous membranes directly on a person or onto inanimate objects and through indirect contact transferred over. So example, COVID-19, RSV, SARS, a lot of your upper respiratory illnesses are transferred this way through indirect droplet. Some forms of meningitis can be transferred this way. COVID-19 is definitely transferred this way, and there's some suspicion that it's actually airborne as well, and that they think that's why it was so easily transmitted initially when it came on. But we'll talk about that later. Prevention of contact transmission, of course, the common practices. We'll go over the general precautions later, but basically it's all the things you would think about. So gloves, hand washing, try to cleaning equipment in between runs, especially after a patient that you have suspicion for communicable infectious disease. So airborne transmission is different in that the infectious particles of the specific disease are so small that they actually will float in the air for large periods of time. So that's why they're called airborne, right? So they are so small, they float in the air, they can kind of move around with airflow, and they can travel a lot larger distances, okay? So these are the disease processes that you would need to wear N95 on. So this would be measles, chickenpox, tuberculosis, and then there's more evidence that COVID-19 is transferred, possibly airborne. So that's kind of why we made the move to N95 masks kind of later on in the epidemic. Again, these particles are so small that, they float in the air, and also just a regular surgical mask or a paper mask that you see actually will not filter out the particles. So that's why you need a specific type of mask. It's N95 mask that'll filter out the particles. So we talked about this. N95 is supposed to filter out 95% of a certain size particles based on the size of the virus and the size of the actual infectious process that's in the air. Also, you can think about ambulance ventilation. Some ambulances have ventilation systems that'll expel air into the atmosphere, and that'll be good in these cases if you're thinking not just COVID-19, but other airborne disease processes. Vector-borne, we're not going to talk much about, but these infections require a intermediate source to transfer. So this would be like rabies, malaria, where you don't really get transfer from person to person. It has to go in between a vector. And then common vehicle is where you see these little outbreaks of, say, E. coli or salmonella, where you have one single source that's contaminated with either usually bacteria, and then that can be spread to multiple hosts to other areas. And then bloodborne transmission that requires actually direct contact with a blood or other infectious fluid. We'll talk about the different types of infectious fluid, but it has to be transferred to either broken skin or mucous membranes to actually transmit the disease. So these diseases wouldn't be just airborne, or they wouldn't be just droplet or anything like that. Examples: hepatitis C, B, and HIV, and we'll talk about some occupational exposures as well. So in regards So in regards to specifically bloodborne pathogens, I think my keyboard's down here. We'll try to use the mouse. So in regards to specifically bloodborne pathogens, this is the fluids in the body that's considered infectious from these sources. Okay, so blood, CSF, pleural fluid, pericardial, and amniotic fluid. Other things that are not considered infectious, so feces, saliva, sweat, tears, vomitus, urine. So, patients with hepatitis B or hepatitis C, if you come in contact with this, it's not going to be as worrisome rather than if you come in contact with blood or some kind of the other fluids we talked about. So the CDC guidelines, as far as universal precautions, we talked about a little bit. So this would be gloves, masks, paper masks, and gowns. It really came about due to concern for transmission of HIV, and this was in the 1980s, and is really just trying to limit that contact bloodborne transmission that we talked about earlier. So basically these guidelines came out in the 80s and said that all healthcare providers should have this minimum requirement anytime there's a possibility that they come in to contact with either blood or some more, one of the other infectious fluids that we talked about. So general approach to patients that we think could possibly have these diseases. This is it's kind of different in the setting of COVID-19 because now we take these precautions on almost anybody. But if you can think back before the epidemic, it might start with the 911 dispatcher. If they're hearing certain things or asking certain questions, they might relay, hey, we have suspicion that this could be a communicable disease. And then after you make contact, you can get more history and say, okay, this could be, and then you can add on extra layers of protection as needed. It's always better to know up front so you can go ahead and have that protection before you go in and see the patient. We've talked about PPE. This is somewhat department dependent. Depends on what exactly resources and equipment you have. Most all places now, especially COVID-19, have N95, respiratory masks, gloves, eye protection as needed. I'll skip over this real quick. So needles and other sharps, we'll talk about that when we talk about the specific diseases. So we're just going to talk about a few brief specific disease infectious processes that I think are important to know in the EMS world. So of course, flu has actually not been as big this past winter because of COVID-19 and the different precautions we were taking, but there's everybody kind of knows flu: abrupt onset of fever, usually a very high fever, non-productive cough, myalgias, headache. There's 3 different types A, B, and C. A is the most severe disease. Thankfully, B has been the most common disease that we've seen over the last 2-3 years before COVID. And it is transmitted through droplet transmission. Okay, so it's not airborne. So if you're, a certain distance away from the person and you're not touching any of the inanimate objects that have these droplets on it, then your risk of actually getting the disease is a lot less. So this wouldn't be something that you would necessarily have to use an N95 for. The bad thing about a lot of these diseases that are droplet precautions is you can transmit the droplets even before you become symptomatic. And that was a big thing with COVID as well. First off, you would have asymptomatic carriers that can transmit the disease, but also before you actually become symptomatic, you can transmit the disease. So it all depends on the viral load that's in the droplets that you're expelling, right? So especially with the flu, you can transmit it about a day before symptoms start. So this can kind of get you in trouble as far as transmission. So vaccine is principal means of preventing morbidity and mortality with the flu. Flu is very difficult in that its genetic makeup of the virus. It can change and shift every year, so that's why there has to be a new vaccine that comes out every year, and it's somewhat of a guesswork by the scientists to try to figure out exactly which type of flu is going to be coming out that year so they can make the virus fit that type. But it is effective, especially in the elderly population. It's not as effective in actually preventing it all the time, but it is very effective, over 80% effective in preventing death and severe mortality. So it can help prevent the severity of the disease, but not necessarily the actually getting the disease. So we'll talk about TB. It's pretty rare now, especially in the Western worlds. We've come close to eradicating it, you could say. We do see it sometimes in special populations. So there are special populations if you run on that if they have these signs and symptoms, you got to be thinking of, hey, this might be what's going on. So we might need to add extra layer of protection. So typically active TB, they'll have cough, sputum, sometimes hemoptysis, but guess what? You see that with almost every other respiratory illness. So there's really not a good way clinically to say, hey, I think this is TB or not. The patient might have weight loss, night sweats, and fevers, but that's also non-specific. You can see with a lot of other disease processes. So like I said, clinically, you're not going to be able to tell if somebody has TB. So what we do, and especially in regards to precautions, is we go off of risk factors, right? So if they have risk factors or other items on their history that is suggestive of tuberculosis, then we'll go ahead and add the extra precautions on. We'll talk about that in just a second. So these are the risk factors. Of course, if you immigrated from a high prevalence country, and I'll show you the map of the high prevalence of TB. The Western worlds is very low prevalence, but we do see them, especially in the homeless population, patients that are incarcerated for long periods of time. If you have HIV and not well controlled with medications, you are increased risk of getting TB. And then any other immunosuppression, so renal failure, if you're immunosuppressed from, say, you're on chemotherapy for cancer, you're going to be at increased risk. So if you see all these signs and symptoms, hey, I'm short of breath, my O2 sat's low, I've been coughing up blood, I've been having night sweats, I've lost 30 pounds over the last 2 or 3 months, and I just got out of jail. I was in jail for 30 years and just got out. That would be somebody that would be at risk, and you need to think about maybe some extra precautions on this patient. So this is just a map of the prevalence of TB. You see the blues are the very low prevalence. So basically the Western world, European, the TB rates are very low. India, South Africa are going to be your higher rates. If anybody immigrated from there, that would be a concern. Now, tuberculosis is airborne transmission. So like we talked about earlier, airborne transmission is going to require you to have an N95 mask, okay? So that's going to be the very small particles. This bacteria is very small, and it can float in the air for some periods of time. So that's why you have to have N95 masks with these patients. There is treatment for this, but it's pretty extensive treatment. It's like 6 to sometimes up to a year of a 4-drug antibiotic regimen to actually eradicate the disease. Okay, so let's move on to chickenpox. We don't see chickenpox as much with the vaccine that came out in 1995. Most all kids are now vaccinated. There's 2 different entities. There's chickenpox, the varicella zoster virus, and then shingles, of course, later in life, which is a reactivation of the primary disease process. Acute chickenpox, so the primary infection of chickenpox, is very contagious, okay? We don't see it as much anymore, so it's kind of funny, but it's described, the rash is described as dewdrops on a rose petal. Any kind of herpetic infection is going to be described as that. You'll see different lesions crusted over. It's usually on the torso and the face that you'll see it. Kids usually do okay with it, and it's mainly self-limiting. However, if you get that primary infection in the elderly community, those are the patients that are going to have more complications. So they can get meningitis, they can get a pretty severe pneumonitis from it and have to be intubated occasionally for this. And then the thing to remember for this, if you see or suspect this, is that it is also airborne as well, okay? So this is what makes it so contagious, is that it's airborne transmission. So if you have suspicion, you're going to want to put that N95 mask on. Okay, so herpes zoster or shingles, it's the same virus, it's just the secondary disease process. So what happens is when you get chickenpox, you get that primary infection with the virus, your body will fight it off, but it will never eradicate the virus all the way. So the virus will lie dormant, and it'll actually live in some of your nerve cells around your spine, okay? And they can just live there forever, the body's fine with it. And then something happens, either old age, you get sick for another reason, you get immunosuppressed, you get cancer, put on chemotherapy, and that virus can then break out again and cause shingles, okay? So I'm sure a lot of you have seen the shingles rash. It's a herpetic looking rash. It's only over one dermatome, and it doesn't cross midline. Those are clinical kind of things you can look at to suggest if this is zoster or not. So yes, sir. Yes.
Once you get shingles, I know there's a vaccine that you can, but once you get it and you're cleared from it, can you get the shot to help prevent? Or
You can. So the shot is to help with severity and because you can think of the shingle shot as a booster to boost your immune system. So as people age, their immune systems just get kind of weaker and weaker, and you can have waning immunity, and that's what makes the virus reactivate. So you can get a booster, which is the shingles vaccine, and it will help that immunity, and it can help the severity of it. You still might get it, but it will help the severity is the biggest thing.
How long will that booster last?
I think it depends on the age of the patient, and I'm not sure the specific recommendations right now about how often to get it. I'd have to look that up, but I know you can get it more than once. Just quickly talking about clinically, the patients are very painful over the area. You can actually see the pain develop before the rash, actually. So you can have this pain develop over this one area, doesn't cross midline, and then you see the rash come on afterwards. When we talk about dermatomes, this is what we're talking about. So, you have all the nerves coming off the spinal cord. Each nerve will have a certain distribution area over the body. So it kind of starts here at the spine, and it'll wrap around the front side here, right? So if you think about what we talked earlier, is this virus, when it becomes dormant, it'll go into the nerve cells along your spine, and it'll just sit there. And then when they reactivate, they'll just follow that one nerve path around, okay? So that's why you see, maybe 2, maybe 3 different dermatomes, but in the same area of that reactivation. That's why you see it. So we talked about being very painful. Usually there's not a cure for it, or I say there's not a treatment that'll make it go away. There's usually just supportive care. There are some antivirals that can help with the length of the disease, but it really doesn't cure it. The body just has to fight it off again. Okay, so switching gears again, talking about meningitis, and specifically a certain bacteria meningitis. There's one called meningococcus, which is very contagious, and it's one of the more severe types of meningitis. So that's kind of why I wanted to hit on it. So there's multiple different types of meningitis, but usually you'll hear viral and bacterial. So bacterial would be the more severe form. Viral meningitis is most of the time self-limiting. Bacterial can be very deadly very quickly. And this specific type of meningitis, meningococcus, is a bacteria that is spread very quickly, and so that's kind of why I wanted to bring it up. It is not airborne, but it is droplet, and you'll see it a lot in patients that live in close proximity to other people, and we'll talk about. So meningitis in general, bacterial meningitis in itself has a fatality rate of 14%. It's a pretty deadly disease when you think about diseases as a whole. They can present as fever, headache, stiff neck, altered mental status. Of course, the stiff neck and the altered mental status is kind of what makes us think that, hey, there could be a CNS infection going on here. Headache is very common. It's kind of hard to tease apart because, headache is common in a lot of different infections. But if you have somebody that's altered and they said, just all of a sudden, I don't have chronic neck pain, and all of a sudden I just have trouble moving my neck is really painful, this would be something you should think about. Seizures you can see, but that's usually later on in the disease process. That usually means that you're starting to having edema, cerebral edema that's causing the swelling. So specifically, so again, we're talking about the specific bacteria meningococcus that causes meningitis. We see it a lot in close living quarters that can be transmitted rapidly. We'll see it sometimes in small outbreaks in military recruits and college dorms, just because they're all living in close quarters. And we talked about, sir. That's yeah. Anywhere that has close quarters, you can see this. All right, so it's if you suspect this, of course, you're going to want to maintain all those contact precautions that we talked about. So gloves, gowns, if you have them available, surgical mask. If these patients end up going to the hospital and ultimately diagnosed with this specific disease, then what the health department will usually do is go back and look at exposures, and we'll give you post-exposure prophylactic antibiotics based on your exact exposure to the patient. Okay, so occupational exposures, bloodborne pathogens, the biggest ones we think about are Hep C, Hep B, Hep C, and HIV. So the hepatitis B virus, with widespread hepatitis B vaccination, it's becoming less of a concern. The occupational exposure after needle sticks has diminished. But in saying that, it is the most transmissible of the bloodborne diseases through needle sticks when compared to Hep C and HIV. And then there's also some non-responders to the hepatitis B vaccine. So this is why we check titers on patients, especially if they're going into or not patients, but healthcare workers. When they're going into the healthcare setting, we'll check titers to make sure they have a certain level of immunity, to know that, hey, if they're non-responders to the vaccinations and they come in contact with a potential exposure, that we then need to give them extra post-exposure prophylaxis. Hepatitis C, it's a totally different virus from hepatitis B, although the symptomatology can look similar. There's no vaccine or post-exposure prophylaxis available for hepatitis C, so that's why it's always important just to maintain these basic precautions when you're dealing with anything that could involve coming in contact with blood. It is less effectively transmitted than hepatitis B, which is good. Just in general about hepatitis C, some people will clear it even if they get an infection of it. Up to 25% will clear it and not have any issues. But 3/4 of the people will go on to have either a latent phase and then become symptomatic, or just have this chronic infection, which can ultimately lead to liver failure and cancer of the liver. So the risk of transmission after a needle stick of a hepatitis C positive patient is 1.8%. So it's still pretty low, okay? So it's not, something that that you need to be aware of and put on the normal precautions, but it's still pretty low transmission rate. There is some treatment for hepatitis C infection now with actual completely cure rates of non-detectable viral loads of up to 80% in these new drugs, but they're very expensive. And then HIV, we won't go into really detail about HIV, but just as far as occupational exposure, the risk of infection following a needle stick of an HIV positive patient is actually even less than hepatitis C or B, is 0.3%. So still pretty low. There is post-exposure prophylaxis. So if you get a needle stick and you go to the hospital, they send off the whole complement of labs, and the patient ends up being HIV positive, then you are available through the health department to get post-exposure prophylactic antivirals. It's usually a 3-drug regimen, and then they'll continue to follow you depending on when the HIV positive patient was in their course of their disease. They might have to follow you 6 or 9 months later just to make sure you don't convert and need more therapy. Okay, so that's switching gears again. So we're going to talk about sepsis and septic shock. We talked about shock a lot. Dr. Duerring did with previous lectures. So we're going to kind of just breeze through some of these sections here. General shock is a life-threatening physiologic state. We all know and heard of shock. It's ultimately a decreased tissue perfusion, which leads to in-organ dysfunction and ultimately death. It's a significant predictor of mortality, especially in the adult population. Pre-hospital management can be challenging because you don't have a lot of different diagnostic and therapeutic resources, specifically when we talk about septic shock. We can kind of try to correct the hemodynamics in regards to blood pressure, things like that. But there's not going to be a lot of other options that we have available to us in the pre-hospital setting. So the pathophysiology of shock, it's a widespread reduction in tissue perfusion, which ultimately will lead to cellular death. And then the cellular death will then release more cytokines and other chemical just entities that will cause the whole cascade of events to happen, where ultimately the organs shut down and will die. So we talk about shock. There's 2 different relationships that I'm sure you're well aware of. Blood pressure is equal to cardiac output plus peripheral vascular resistance, what Dr. Duerring was talking about earlier some. And then cardiac output is equal to your heart rate plus your stroke volume. We'll talk about different reasons why each one of those can be affected. So any condition that lowers the cardiac output or the peripheral vascular resistance can decrease the blood pressure and lead to a shock state. And then we'll go over the 4 types of shocks. You all know these, but it's always good to just kind of go through and remember these. So when we talk about shocks, usually the the best way to visualize it in your mind is that there's a pump issue, there's a fluid issue, or there are the issues with the pipes, right? So in hypovolemic shock, you have issue with the fluid, right? So you've lost fluid somewhere. It could be, like we talked about earlier, it could be in trauma where you have blood loss. It could be a GI bleed. It could be GI losses, like a lot of diarrhea or vomiting. It could be cutaneous loss, such as burns, and this will all lead to hypovolemic shock. The specific type of shock we'll talk about today more in detail is distributive shock, which is you can think of as the pipes just got a lot bigger or the tank got a lot bigger, right? So that's why we try to do things like give more fluids and also add on vasopressors to make those pipes get smaller back to their normal size again. Sepsis, which is what we're going to talk about. Spinal cord injury is the same type of shock because you lose the nerve distributions to the vasculature, and the vasculature just loses all its contractility. So that's why you get shocked that way. And then anaphylaxis again through those chemical and allergic mediators. And then the second to last one, obstructive shock, which is the actual pipe obstruction. You can think about it. Pulmonary embolism, tension pneumo, cardiac tamponade. So this is an actual mechanical issue, a blockage of the cardiac output. And then cardiogenic shock, which is the kind of the easiest to think about, is just a straight pump problem, right? You have an MI, you have heart failure, you have some kind of acute valvular process that's going on that's making your pump not work. So those are the 4 general categories of shock. You can be tachycardic hypotension. Y'all all know this. This is what we see all the time. You can have JVD or jugular venous distension and obstructed and cardiogenic shock. You see that because that's the backup of venous flow. Patients, their mental status is can be a late finding, but you'll see agitation, confusion, and then tachypnea and dyspnea. You can see that not only in primary pulmonary infections, but you can see that just because their metabolic rates are so much higher, they're trying to compensate, so they're just tachypnic for that reason. And then cyanosis, pallor diaphoresis, and we'll talk about skin exam more. So we talked about tachycardia, hypotension, right? Everybody kind of knows that. We talked about earlier also the shock index, which is your heart rate over your systolic blood pressure, okay? It's really important in adults, and you know, we kind of do this without thinking already. We kind of say, hey, their heart rate's high and their blood pressure low, that's bad. But you can kind of look at it and it kind of makes more sense this way. So the normal shock index is anywhere from 0.5 to 0.8 to 0.9. Again, this is just going to be in adults, not in kids. Anything over 1 is going to be concerning. So you can just think about if your heart rate is ever higher than your systolic blood pressure, then that's concerning, right? So that's going to mean it's over 1. And then a skin exam on these septic shock patients are really important. You'll see mottled extremities. You can see, and specifically septic shock, you'll actually usually see warm extremities because you have that vasodilatation and all the excess fluid and blood flow to the lower extremities. And you can see some cyanosis, mottling, things like that. Usually with cold extremities, you're going to be thinking more of a cardiogenic shock or a pump issue. Okay, so the kind of main event here. So septic shock, it's a type of distributive shock. It's usually actually the body's response to the infection, not the infection itself. It's kind of the body overwhelming its response mechanisms to try to control the infection. But in that regard, it releases a lot of different chemical mediators that will cause vasodilatation and lead to the hemodynamic issues. Usual causes, UTI is most common. Pneumonia, we see it a lot, but you can see it in cellulitis. You can see patients that are bacteremic with no really outward signs of infection. So these would, I really think about on the dialysis patients, because if you think about it, you know, they're accessed through their bloodstream all the time. So they have really high rates of just getting bacteremic, okay? So they can have signs of sepsis, even though they don't have any other outward sign that there's another infection going on. So interventions, the cornerstone is to be able to recognize it, right? Which we've kind of talked about the different signs and symptoms. Early reversal of hemodynamic compromise is really important. And then early infection control, right? So 2 of those 3 things is going to be in the EMS realm, right? We might not be able to get infection control. We might not be able to give antibiotics, but we can do the other 2 things, okay? So in regards to fluids, you know, there's no set amount of fluid that is optimal for septic shock. Kind of the teaching, the older teaching was, you know, 20 cc's per kilogram or 30 cc's per kilogram, which in a normal adult is, you know, anywhere from 2 to 3 liters. We've kind of changed over to a more of a less fluid-oriented approach and more kind of early vasopressors. But in the field, I think it's totally appropriate to start with IV fluids to see if somebody is fluid responsive, which is what we call. And like I was talking about, depending on transport times, it might be advised to start vasopressors on a patient before you get to the hospital if they're persistently hypotensive, if they're not fluid responsive, or if they have other high-risk features that you're worried about volume overloading them with too much fluid. So those would be patients with really severe heart failure that might be living on, more fluid at baseline anyway, patients with renal failure because they're not going to be able to get rid of any of the fluid that you give them. And so it's really important to think about when you volume overload somebody or give somebody too much fluid, what's going to happen, right? So all that fluid is going to go to the lungs and cause pulmonary edema. And that's where you can start running into issues with breathing, ventilation, and you might have to intubate patients if you give them too much fluid. So that's kind of why we've transitioned to a more early vasopressors in these patients and not just slamming them with 6 liters of fluids like we used to do. All right, so again, our goal is to reverse the abnormal hemodynamics, right? So we're trying to increase the blood flow to the extremities, to those tissues that are not getting perfused as well. Like I talked about earlier, the fluids, I would be very cautious in giving more than 2 liters in the pre-hospital setting. If you've given 2 liters and they're still not responsive, and you're thinking septic shock, then these patients are probably going to need vasopressors. Usually our goal of blood pressure is a MAP of 65 or a systolic blood pressure of 90 to 100 is our usual kind of goal there that we go off of, and we titrate our vasopressors in the ER to a MAP of 65. And then I'd like to talk about what I talked about earlier with being tachypnic. These patients would be tachypnic. They could be hypoxic just from being metabolic overload. They can also be hypoxic because they're not perfusing their tissues, their extremities, right? So your pulse ox might be reading lower, not because they might have a primary pulmonary issue, but just because they're not having enough cardiac output and they're going to have a decreased oxygen saturation in the peripheral extremities, okay? So that's got to be something you think about too. Supplemental oxygen as needed, 92 to 94% range is kind of what I like to go with. It's not necessarily, you don't necessarily have to give them oxygen if they don't have a low O2 sat, right? And we've talked about that before as well. So those are the big things, right? So in summary, recognition is key. It may be subtle. We talked about in kids, it can be very, very subtle, right? They can maybe just have tachycardia and be in a shock state. Usually you'll see some more signs in the adult population. You'll see more skin findings can be very important to key in on, that you can say, hey, this person doesn't look well. They have mottled extremities. I think they might be shocky, their heart rate's up. They might not be hypotensive yet, but their heart rate's up. So, I'm thinking, hey, do I need to start resuscitating them more aggressively? IV fluid resuscitation, early vasopressors is needed, and then supplemental oxygen as needed as well. And then, of course, definitive care, source control, which is that third prong that we talked about that's important, which would be IV antibiotics, or if this patient needs a surgery to take care of their intra-abdominal infection or something like that. So that was kind of a brief touch over everything. That's all I had. I know there was some questions about COVID-19. We can see if there was any questions specifically about this so far.
I haven't received any on the chat box.
Okay.
What we were discussing earlier was we have gotten a lot of questions from field personnel and from patients and patients' families about the different types of COVID-19 tests. How long do they take? How accurate are they? If you could speak just a little bit about that.
Yeah. So, and in no regards, I'm an ID specialist or epidemiologist, but so there's usually 2 different types of COVID-19 tests. There's the PCR test and there's the antibody test. Okay, so the PCR test is actually going to test to see, is there virus in your body? Okay, the antibody test is the one that's going to show, do you have antibodies to the virus to say either you have an active infection or you've been previously infected with it, okay? Most places are doing the PCR test. Now, under PCR tests, there's usually three different tests as well. So there's a rapid test, which can be done within 1 to 2 hours. Those are very rare. We have, even in the ER, we only have like 10 a day that we can do with those. But those are PCR tests. The one that you usually will see at like an urgent care or a CVS will be a send out test. It'll take 2 or 3 days, but those usually are the PCR tests. Now, if you go to an urgent care or CVS or something and they give you a test result, say within the next 2 to 3 hours, that's usually one of the antibody tests I was talking about earlier, okay? So if you get a test back quickly, and you're not in like an ER or in the hospital, then it's most likely not a PCR test. And the main difference is that the PCR is going to be pretty much what we're using as the gold standard. It doesn't have 100% specificity or sensitivity, but what we are using it is the gold standard. So, it has very low false positives, very low false negatives. The antibody test, on the other hand, has a lot of false positives and false negatives. So the most important question to ask is this a PCR test or an antibody test?
There's also a NATT, are you familiar with that?
Yeah, so that's going to be the same as the PCR.
Okay.
Yeah, that's just the way they test the PCR, but that's the same thing, the NAAT, nucleic acid amplification test. That's going to be the same as PCR.
Okay.
Yeah, so those are the big things. So if somebody says, yeah, I tested negative, the most important question is just to ask, was it a PCR test? Most of the time, some of the times they might not know, but if you know that, that's the most important thing.
So people ask all the time, was that a rapid test or a send-off test?
Mm-hmm.
So what you're saying is PCR test can be either.
It can be either, but you're most likely not going to get a rapid PCR unless you're in a hospital. So if somebody says, from what I understand, if you go to like an urgent care and say, oh yeah, I got a rapid test, that's most likely the antibody test. From what? Sorry, antigen.
It's like the chromatography.
Yeah,
antigen
sorry,
test,
antigen, not antibody. Yeah. And what do y'all doing at Children's right now? Or y'all have the?
We only do PCRs.
Yeah.
The antigen test isn't as sensitive or specific in kids, and so we only do PCRs at Children's.
Yeah.
And it's about a 24-hour turnaround.
Yeah. We do
Depending on when you get swabbed versus when the batches are running.
Yeah. And since we ran so low on the PCRs and the ER UAB, we would do the antigen first, and then if that was positive, then do the PCR, just because the antigen is not as sensitive. Sorry, antigen, not antibody.
Great. Thank you so much, Dr. Payne. Great lecture, timely topic. Thanks again, Dr. Duerring. I do want to mention one thing to everybody. There's going to be an event coming up on April the 23rd at the Garndale Civic Center. It's Alabama Emergency Nurses Association and the Alabama EMS Association are putting on a one-day symposium conference. You can go and register for that. It's $20 registration fee is all. And if you need to know how to register for that or to get the information, then you can contact me at www.centralfire.com. Also, everybody, please remember to fill out an attendance form for today. If you're online, you can find the link in the chat box. If not, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated response with a link. Today's password is pathogen. Thanks everybody for being here, and we will see you next time.